making sense out of anything. If you ask my 18-year-old daughter, she would tell you that's not possible for me to do. But let's start here. So I don't know what the CT shows. I don't know what the solid organ injury is. But here's what's in the trauma room: 6-year-old who, before you were successful in Arizona getting a booster seat bill passed, was restrained in a 3-point restraint improperly and crashes his car, or the family crashes the car, and this is the injury he's got. So what happens mechanistically is that lap belt that rides up over the anterior superior iliac spine compresses everything between the anterior abdominal wall and the spine, and so everything's at risk in there. If you just want to play the odds and sort of say what's likely, so I'm in the trauma room and the trauma page has gone off, and I've heard the mechanism, and he's got abdominal pain, so most likely things: a splenic injury, followed by liver, followed by kidney, followed by pancreas. But in the back of my mind, I'm always worried about that dreaded bowel injury that's down there also. So they've got a CT and they've got some free fluid, and is it also a bowel injury? So I don't have a CT yet, I just got a patient with a lap belt. So I start with the first break point in the algorithm is stable or unstable. Am I going to the operating room, or can I complete a workup? Unstable patients go to the operating room. There is no difference between the pediatric patient and the adult patient. If they're unstable, if the FAST is positive and you don't have another source of bleeding, that's where you go. And if you're not there, you're in the wrong place. So if they're stable and you can get to a CT scanner and they've got something that looks like an angiographic target, you can use that if going to the operating room next is not the next best thing to do. And I think that while somewhat late adopters as pediatric trauma people, because most of our patients also have a head injury, I think in the solid organ injury, or specifically the isolated solid organ injury, we should follow our adult colleagues' leads and practice a damage control resuscitation or a hypotensive resuscitation and not pop the clot off. So now you got your CT. All right, so CT shows this bad splenic injury, and there's also a fair amount of free fluid down there, and it looks like it's blood, but maybe it's blood, maybe it's not. So now what next? Well, again, the next algorithm really relies on hemodynamic stability. Patients that are unstable with that CT, they go to the operating room, especially if they've got a head injury, because the only two things that make a difference in outcome of patients with brain injury is that you don't let them be hypoxic and you don't let them be hypotensive. And so don't let the patient be hypotensive. So hemodynamically unstable patients go to the operating room. Stable patients can continue down the algorithm or the path of non-operative therapy until they either need to go to the operating room for something else in their abdomen, or they've received more than half of a blood volume of transfusion, and in the pediatric patient, that's about 40 cc's per kilogram. If they've received that, then the risk of getting continued transfusion exceeds that of operation, so probably operation is greater. And there's a question about whether or not you do it in a patient who is going to be unexaminable for a period of time, but there's a little controversy around that. I think things that have fallen out as mandatory needs for operation are a high-grade injury. So grade in this second point of the algorithm really doesn't matter. It's stable or unstable. I don't care how bad it is. I just care if they're stable or unstable. Patients with brain injury, it used to be said they have to go to the operating room because you can't let them be hypotensive. Well, I agree, don't let them be hypotensive, but just the presence of those two injuries does not mandate a laparotomy. And then blush on CT scan, and we have plenty of evidence that shows that blushes in pediatric patients can be managed non-operatively and maybe even non-angiographically because of the vasoreactivity of the vessels. You may see a blush initially and still that patient remain relatively stable. So back to the article that I sort of teased you with in the first one, where Dr. Stylianos and the ABSA group sort of laid out for us. Now that we've made a decision to not operate initially, or there's no hard indication to operate initially, now what do we do with this patient? Well, they outlined for us a decade and a half ago where to put the patient. This grade needs to go to the ICU, this grade needs to go to the floor, this one needs blood, this one needs this length of stay in the hospital, this one needs repeat scanning. And a friend of mine, Marcin McVeigh, and the group in Little Rock really sort of challenged that paradigm and said, None of that matters. None of it matters. The only thing that matters is hemodynamic stability. If they're hemodynamically stable, I don't care what grade it is. They come in, they get this therapy, and when they're stable, they move to the next sort of rung of therapy, and they keep doing that until they're ready to go home. And grade is really irrelevant in that. And again, the analogy I use is somewhat, again, like chemotherapy. So we've got an illness, injury, or tumor, and you hit it with a treatment, chemotherapy, or non-operative management with a long, protracted course of bed rest and blood and repeat scanning and all this. And then you find that that's successful, and you start peeling back the therapy or the intensity of the therapy until you get to a point where you start to see some failures. We're not at that point yet. And so Marcin and the group said, get rid of all these other stipulations, just base it on hemodynamics. So the current recommendations for care that I had used, and I'm going to tell you about sort of a new trial that's coming up, run by Dr. Notrika. But what we had used was we broke the grade of the splenic injury and the liver injury and the renal injury in about the middle. And quite frankly, grades 1 through 3 are minor injuries. Went to the floor. They got hemoglobin levels every 6 hours until they were stable. They got some pain medicine. They got some anti-nausea medicine to keep from throwing up. And the higher grades went to the ICU and got the same essential treatment, and they were at bed rest until they had a couple of hemoglobins that were stable. Hemoglobin stability we've defined as about 0.7 milligrams per deciliter times 2, and then we start to space it out until they're ready to go home, or daily if they're staying. And then patients go home when their hemoglobin's been stable for 24 hours, they're tolerating liquids, they don't have to tolerate a regular diet, and they're able to get to the bathroom with minimal assistance, and they don't have fever or otherwise a systemic inflammatory response. They're ready to go home. And so that can be as soon as 24 hours. It can be much longer than that. But quite frankly, utilizing that protocol, Dr. McVeigh and her group ended up showing that when you compared that to treatment under the old ABSA guidelines, that you lowered the average length of stay from about 4 days to about a day and a half, or 1.9 days. So we are coming back on the intensity of the therapy. We follow them up in a week, and some of that follow-up for the lower grades can be done by phone by the nurses or nurse practitioner. We don't necessarily image for any grade of injury unless they have symptoms, and the symptoms typically are fever, persistent pain, or early satiety, as some of these things press on the back of the stomach and cause cysts. We do limit their contact activity, and I'll tell you, this is one of the hardest things because every kid that comes in is a future Olympian, and the parents are just devastated that the 6-year-old is going to be out of soccer for the next week because they were going to go to the Olympics. But we use 2 weeks per grade of injury. So a grade 3 splenic injury gets 6 weeks out of contact activity. And I know y'all saw the I guess it was the Dallas Cowboy or whatever that went back in 2 weeks. And I'll tell you, yes, he did. But he shopped around for 3 doctors to get somebody to sign off of that, and the NFL made him sign a waiver. So we don't know the end point yet. At some point, if you go back too early, you're going to get a recurrent bleed. But we don't know what it is. This is what we do presently. So when do you abandon this? Well, I can't harp on it enough. Anytime they're unstable, it really is no different than the adult patient population from there. And I personally think relatively unstable, the transient responder with the bad brain injury who's got brain tissue that's marginal should not be hypotensive. And if what you need to do is go operate, pack a liver, take a spleen out, pack a kidney, do something to stop that transient hypotension, it's worth doing. If they exceed about a half a blood volume, and sometimes if they just have such a significant systemic inflammatory response, we will see a kid periodically that'll knock off liver or spleen, and they'll have such a response to it. And I guarantee if you measure their IL-6 levels, they're out the roof, but you just cannot stand to watch them because they've got peritonitis, they're tender, they've got fever, they're tachycardic, and I can't always tell the difference between that and a concomitant bowel injury that I'm missing, even though the risk is low. And so sometimes we'll go look. Sometimes we'll put a scope in those people, wash them out, or just operate on them. I mentioned this, not really. I'm not going to go into a complicated discussion about the systemic inflammatory or the overwhelming post-splenectomy sepsis, but to say that if you're going to watch these people, if you're going to go to the operating room with a kid with a splenic injury, you need to be cognizant of the immunologic consequences of losing a spleen and have a protocol in your hospital for how to manage that post-splenectomy. All right, so next injury is this, again, direct blow to the middle of the abdomen. We talked about earlier, handlebars to the mid-abdomen or the karate chop from the brother or something like that. But again, everything gets compressed between the anterior abdomen and the spine, and the pancreas is at risk there. So this is a fairly fresh CT of a pancreatic injury. So do you operate on this or don't you operate on this? Well, hemodynamically stable, no, but the big question here is the duct. It really is all about the duct. And on this first CT, I can't tell you that. I just can't tell you on it. It's sort of muddy around the neck right there, but I can't tell you. And the serum amylase isn't going to help you any because early the serum amylase may be absolutely normal, and it's normal in some big percent, about a third of patients that have significant injuries. If you watch it for a period, though, those that have major ductal injuries, the amylase and lipase will go up. And so they, along with a clinical examination, give you a sense that the injury that you saw earlier on the CT may be a significant injury with a ductal component to it. So the initial CT is often misleading. In those cases, we will often let them sit 12 hours or so, give them some oral contrast just to light up the C-loop of the duodenum, give them IV contrast, and then do thin cuts just through that area of the pancreas just to look at it again. Because what happens is you get some edema that forms, and you're much better able to see the crack in the split in the pancreas and the transection of the duct. The next stage of treatment really is predicated on the duct. So just like everything else, the pancreas has a AAST grading scale to it, and the break really is between grade 2 and 3. Ductal injury, no ductal injury. And you can go to the pediatric literature and find just tons of small case reports saying it's perfectly safe to not operate on patients with pancreatic injuries. I really take issue with those case reports. One, because they're small and they report the cases that were successful, and the truth is that very few of these patients had interrogation of the duct. And it really is about the duct. Yes, I do believe that the path of least resistance through a 5-year-old's pancreas is that it's going to drain and it might heal at some point. But we've got sort of the patient burned in our mind, the index case that we talked about earlier of the patient who was in the hospital for months and months and months on TPN, got 3-4 drains put in the pseudocyst in the abdomen, whereas I know if I'd have gone on day 2 or 3 and done a laparotomy and taken out a distal pancreas, they'd have been home in 3 or 4 days with much less morbidity than they suffered from the delayed treatment. So I must say my feeling about this is that if they're hemodynamically stable, you can start to watch them. If the abdomen is benign, you can watch them. If you believe that they have a grade 1 or 2 non-ductal injury, you can continue to watch them. At some point, however, if you believe that they've got a ductal injury, my personal feeling is that you ought to go to the operating room and treat them exactly like an adult, distal pancreatectomy or another procedure for the higher grades that move closer to the head. I don't think this really is any different. I think the big difference is we don't interrogate the duct like the adult trauma patients do. So this is sort of my recommendation, my personal recommendations for pancreatic injury. Liver injuries in the pediatric patient, really no difference in the algorithm than that for spleen. Those that are unstable go to the operating room initially. Those that fail non-operative management because of blood transfusion or transient hypotension go to the operating room. But otherwise, you can watch them non-operatively, perfectly safe. Those patients, however, I want to talk sort of about what happens later, though. The patient who still has the systemic inflammatory response 2, 3, 4 days later, they're still tachycardic, they look terrible, they're in pain, their belly's distended. we should look for the complications of a liver injury, which primarily are bile leak early, because bile is so irritating to the peritoneum that it gives them this inflammatory response, and they may not be bleeding, but they're having peritonitis, and it's from this, and it's very difficult to watch and sort out. And so we've gotten to a point where we evaluate for this very early, between day 3 and day 5. If they've still got an inflammatory response, we get a HIDA scan. And if the HIDA scan demonstrates leak from the liver, then we've adopted a practice of going to the operating room, putting a laparoscope in their abdomen, trying not to touch the liver, trying not to vigorously spray that thing, but really wash the peritoneal cavity and get rid of that inflammatory response and lay some drains in above and below the liver and get out. And what we've seen is that about 4% of all the patients that are seen will develop this bile leak, and that if you will wait on these, most of these will close. A few of them, we then do a secondary sphincterotomy and ERCP later to promote drainage, but almost all of them will close at some point, and almost none of these do you have to operate. The other consequence that you get from non-operative management of the liver injury is the liver abscess, like you see here. So bad right lobe injury managed non-operatively. And what's paradoxical is that if you go operate on this, the chance of it getting secondarily infected ends up increasing versus percutaneous drainage and non-operative treatment. So for this, my practice would be to put a percutaneous drain in this, drain it even up to 2 times before I dove in and tried to operate on this thing if I've taken that path. Most of them develop within the first couple of weeks. CT guidance is fine. There's some question about whether you should go transpleurally or not because they develop pleural abscesses, but draining them a couple of times is fine. Last solid organ that I'll talk about is the kidney. So kidney is contained within gerotas, and in this one, just like the pancreas is about the duct, the kidney is about the collecting system. So if the patient's hemodynamically stable, then great. You can start down a path of non-operative treatment. If the collecting system is open, then you need an adjunct to help drainage and facilitate closure, because there is a phenomenon that once you start to expand the gerotus capsule or expand that hematoma, it just gets easier and easier. So if you're leaking urine, it's going to expand even faster in that area. So we do delayed images on patients with known GU injuries. And again, there's a grading scale that is predicated on the vessels and the collecting system. We do repeat imaging on this. So where we don't repeat imaging on livers and spleens and pancreas, we do repeat it here because the signs and symptoms of urinary collecting system obstruction and UPJ obstruction and further destruction of the kidney can be asymptomatic and silent. And so for that, we do get an ultrasound the next day that's feasible, and we use the ultrasound to follow them so that we don't have to scan them after that. We give them the same management as the spleen or the liver as far as hemodynamic stability and when to go to the ICU and when to eat and when to go home, same criteria. But we do follow them up at 1 month and 6 months specifically to see that they're not developing hydronephrosis from obstruction of the collecting system, and that they're not developing hypertension from the healing of the parenchyma of the kidney itself. So, in conclusion, my take on management or sort of unraveling non-operative management of pediatric solid organ injuries is that it's changing. The dynamics are changing. But I think clearly we begin with hemodynamic stability. If they're hemodynamically stable, we begin down a path of non-operative management. And then the therapy for it in the hospital, how long you stay, what your follow-up is, I believe is changing. It's going to come back, and we'll try to be as least invasive as possible or less intensive as possible until somebody reaches a point that says, whoa, we're having complications or failures at this level, and that'll be the point that we'll stop. And I don't think we're there yet, so it's still dynamic. I do believe it really does help to have treatment algorithms, and this is where I'm so grateful to Dr. Notrika and his group, because at his hospital and in many pediatric hospitals that he's leading a research program, he's developed an algorithm for the non-operative management of pediatric solid organ injuries, and I think this is going to be very successful, and it's going to sort of be the next big paper that defines how we do this in the country. So I'm very grateful to him for doing that. And I think those of us that do this work, that treat the kidneys and the spleens and the livers non-operatively, need to be prepared and sort of have the what if, what next question answered before we get to the patient, such as are we going to drain? Are we going to go to the operating room and wash them out for bowel leaks? Do we have ERCP and sphincterotomy? Do we have urology to do stenting? Are we going to stent everybody that has calyceal injuries? And so those are the things I would encourage you to integrate into your algorithm for that. So again, I really do appreciate you inviting me. I appreciate the opportunity, and I'll take questions at the end, I guess. Thanks.